Thank you very much. I am really glad to present my favorite abstracts from ESMO 2022 on colorectal cancer and ACC that are the most interesting results. So let's start with colon cancer, just focusing on localized tumor because we really have an amazing results from the NICHE-2 trial presented at the Presidential Symposium. 112 patients with non-metastatic mismatch deficient colon cancer, at least T3 or nodal positive at the radiological analysis, received 1 dose of ipilimumab and 2 doses of nivolumab before surgery. Co-primary endpoints were safety and 3-year disease-free survival, with secondary endpoints including major pathological response and pathological complete response. Disease-free survival data are yet to be reported, but the primary endpoint of safety was met, with only 4% of patients experiencing a grade 3 and 4 immune-related adverse events, and 2 patients experiencing a delay in surgery of more than 2 weeks. And with a median of 5.4 weeks from the first dose to surgery, the pathological response was observed in really 100% of patients, with a major pathological response in 95% and complete pathological response in 67% of patients. No patients had a disease recurrence after a median follow-up of 13 months. These are impressive results. The waterfall plot was really amazing and received a long applause from the audience during the session. In my opinion, this trial is not immediately practice changing, at least in our routine practice, as we have to wait just for data for the primary endpoint of 3-year disease-free survival. But in general, a major consideration for the use of neoadjuvant immunotherapy relates to patient selection. In the adjuvant setting, in fact, the decisions is made according to the postoperative pathology. Whereas in the neoadjuvant setting, I think that the patient selection is more challenging because the decisions are based mainly on CT scans, assessment of the tumor. And we know that the radiological assessment of the local stage is particularly difficult. For instance, to differentiate among a T2 and a T3 tumor. And so the risk is to overtreat patients with tumors that otherwise can be cured with surgery. And I think that this is an area that needs further development. And probably in my clinical practice from tomorrow, I will consider this neoadjuvant strategy for those patients with a clearly locally advanced disease. For example, a T4 tumor with an infiltration of other organs, or when a non-operative approach is to be considered due to high risk, for example, of surgical risk. The second abstract that I am really happy to present to you is focusing on colorectal cancer in advanced setting and a heavily pretreated population. This is the FRESCO-2 trial. This is a phase 3 trial that evaluated a treatment with a novel oral therapy fruquintinib plus best supportive care compared to placebo plus best supportive care in heavily pretreated Western patients with a refractory metastatic colorectal cancer. Patients were eligible if they were previously treated either with chemotherapy, anti-VEGF therapy, or anti-EGFR if the case, or immunotherapy if MSI high, and the primary endpoint was overall survival. The median overall survival was 7.4 months with fruquintinib versus 4.8 months with placebo, with an hazard ratio of 0.66. And therefore, the trial met its primary endpoint. And the median progression-free survival was 3.7 months versus 1.8 months, respectively, with an hazard ratio of 0.32. Grade 3 and 4 treatment-related adverse events occurred in around 60% of patients in the experimental arm and around 50% in the placebo group. So overall, we can conclude that fruquintinib was well tolerated. But nonetheless, I would also be eager to see the quality of life analysis, which also is very important, together, of course, with the survival benefit in this clinical setting of really heavily pretreated patients. So we have also to focus our attention to the quality of life of our patients. These results are really encouraging since they address a huge unmet need in the treatment landscape of metastatic colorectal cancer. Fruquintinib provides a possible new option with meaningful survival benefit in heavily pretreated patients with still a good performance status of 0 to 1. So let's move on, and other interesting abstracts have been presented covering the topic of advanced ACC in first line. I can anticipate that they are no practice changing in my opinion, but really deserve to be mentioned. Two late-breaking abstract presentations show encouraging efficacy data from phase 3 trials of first-line treatment with an anti-PD-1 antibody with or without a kinase inhibitor. The phase 3 Rational 301 trial evaluated the non-inferiority of the anti-PD-1 antibody tislelizumab versus sorafenib in patients with unresectable ACC in first line. The study consisted of mostly Asian patients, and most patients also had hepatitis B. Overall survival superiority for tislelizumab compared with sorafenib was not met, but the study still reached its primary endpoint of overall survival non-inferiority. Treatment-related adverse events at grade 3 or higher were less frequent with tislelizumab at 48%, whilst were 65% in the sorafenib arm. In conclusion, my conclusion is that single-agent tislelizumab demonstrated a clinically meaningful anti-tumor benefit versus sorafenib with a favorable and manageable safety profile. We know that there are currently no single-agent checkpoint inhibitors approved in this setting of first line. Nonetheless, we can say that immune checkpoint inhibitor monotherapy is active in ACC and not worse and better tolerated than sorafenib. Therefore, in my clinical practice, in those cases where atezolizumab plus bevacizumab is not feasible, that is still the standard of care in first line, but for example is not feasible due to a high risk of bleeding, I consider, for example, an immune checkpoint inhibitor monotherapy with durvalumab after the Himalaya trial results, or nivolumab after checkmate 549, as a possible alternative to sorafenib or lenvatinib. We also have positive results in another phase 3 trial of the anti-PD-1 antibody camrelizumab plus the TKI inhibitor rivoceranib, also known as apatinib, versus sorafenib. Most patients, also in this case, across both groups were Asian. And also in this case, the most common etiology was hepatitis B virus infection. The median overall survival with camrelizumab and rivoceranib was 22 months, compared to 15 months with sorafenib, and an hazard ratio of 0.62. The confirmed objective response rate was 25% with camrelizumab plus rivoceranib compared to 5% with sorafenib. That is what we can expect with this drug. Grade 3 and 4 treatment-related adverse events were experienced by a high rate of patients, 80% of patients in the experimental arm, versus, as expected, around 50% in the sorafenib group. I think that an extrapolation of this positive data in overall survival to a non-Asian population should be not routinely recommended. In particular, given to the high rates of hepatitis B virus infection seen in the underlying etiology. And moreover, we have also to pay attention to the patient selection, because a careful patient selection must be required given the high incidence of grade 3 and 4 toxicity seen in the combination arm, and especially hepatotoxicity that was around 30%. Finally, the third phase 3 trial in advanced ACC, that is the LEAP-002 study, evaluated a first-line lenvatinib plus pembrolizumab versus lenvatinib plus placebo in patients with advanced and untreated ACC. So the setting is the same as the other two previous trials, with no main portal vein invasion. The primary endpoint of overall survival and progression-free survival were not met, and with a statistical significance. And I think that this trial, in any case, even though it is formally negative, it deserves to be mentioned due to the high median overall survival of 21 months with the combination versus 19 months with lenvatinib monotherapy. And the combination regimen also induced a high overall response rate of 26%. I was really surprised and a bit disappointed to see the lack of a significant benefit with the combination. But we have also to mention that overall survival with lenvatinib monotherapy is the longest we have ever seen with a TKI inhibitor alone, that is 19 months, which is also even longer than the median overall survival with lenvatinib in the REFLECT trial, that was the registration trial. And here we had a 13 months median overall survival. This trial is not practice changing, and the standard of care in first line still remains atezolizumab plus bevacizumab. But in addition, I would say that at the moment, my take-home message for this trial is that lenvatinib, rather than sorafenib, should be strongly considered as an option in case of immune checkpoint inhibitor contraindication. So I hope you enjoy my personal highlights from the ESMO 2022, and thank you very much for your attention.